It is Monday morning. There are 35 pending Optum prior authorizations in the queue. 5 need to go out before noon. There's an 11 a.m. peer-to-peer review on a GLP-1 denial, and the physician taking that call has a full schedule starting at 9. This overwhelming volume represents the verified national average across all medical specialties and practice sizes. To find the baseline for this crisis, we have to look at the 2024 American Medical Association Prior Authorization Physician Survey. According to the AMA, physicians and their practices complete an average of 39 prior authorization requests per physician every single week. Processing those 39 requests consumes an average of 13 hours of physician and staff time. These 13 hours represent nearly 2 full working days per physician per week, stolen entirely from patient care to manage administrative paperwork. The burden is so significant that 40% of physicians have been forced to hire staff who work exclusively on prior authorizations. This reliance on dedicated coordinators highlights a failing brute force strategy. Practices are throwing expensive human labor at an administrative bottleneck, mathematically outpacing them. Even with dedicated staffing, the friction remains high. 31% of physicians report that their prior authorizations are often or always denied. The January 2026 Kaiser Family Foundation report on Medicare Advantage provides a macroscopic view of where these denials originate. United Health Group, the parent organization of Optum, showed a denial rate of 12.8% in 2024, the highest among all major Medicare Advantage insurers. This represents a systemic pattern. In 2024, nearly 53 million prior authorization requests were submitted to Medicare Advantage insurers, with approximately 4.1 million of those requests resulting in a denial. Because practices lack the bandwidth to fight these decisions, only 11.5% of those 4.1 million denials were ever appealed. However, when practices do push back, the results are lopsided. 80.7% of those appealed denials were overturned and approved. An 80.7% overturn rate confirms that the requested care was medically necessary all along. These denials are almost entirely the result of documentation and data routing errors that practices lack the bandwidth to correct, leading to millions in abandoned revenue. Navigating Optum's specific infrastructure is significantly more complex than standard prior authorization workflows. Optum operates across 3 distinct plan silos: Optum Rx for pharmacy benefits, Optum Care for managed care, and Optum Medical Network for network-based services. These silos are fractured. Each one requires a different portal, a separate submission path, and unique medical necessity criteria for the same services. These payer policies also rotate quarterly, meaning the rules for approval are constantly shifting. To secure an approval, coordinators must cross-reference the patient's subplan, procedure code, and current quarter's policy to hit an exact target. Submitting an Optum Care narrative into the Optum Rx portal results in an automatic, predictable denial. This structural complexity is why practices with dedicated PA staff still lose 13 hours of physician time per week to the process. The staffing fallacy, the instinct to hire more human coordinators to fight this matrix, is structurally flawed. Human memory cannot sustainably manage a rotating, multi-silo system at this scale. To solve this, high-volume practices are moving toward a specialized, tech-enabled outsourcing model to reclaim their clinical hours. The model relies on an 80-20 architectural shift that combines AI-powered orchestration with human expertise. The first 80% is deterministic. The AI stack reads unstructured clinical notes, extracts the required data, and maps it to specific Optum policy requirements. AWS Bedrock acts as the clinical reasoning agent, pulling documentation and matching it perfectly to the correct Optum subplan criteria. The orchestration layer, managed by N8N, handles the complex routing across 12 major payer portals to ensure the submission reaches the correct destination. Parallel to this, the platform runs eligibility checks to eliminate basic coverage rejections before the submission is even filed. While AI handles the drafting, an AAPC credentialed specialist owns the final 20%, the clinical review, and the actual submission within the practice's EMR. This specialist manages the clinical nuance, handles payer relationships, and prepares the structured documentation needed for successful peer-to-peer reviews. By letting AI manage the memory-taxing data matching while humans handle clinical judgment, The workflow is decoupled from the traditional constraints of the front desk. This 80-20 architecture achieves a standard turnaround time of just 4 hours. This speed is becoming a necessity as the CMS 0057F mandate begins to accelerate decision timelines for payers in 2026. The financial comparison is stark. An in-house coordinator costs $55,000 to $84,000 annually. The outsourced model scales at $399 per week. But the 13 hours a week taken from physicians is the most expensive invisible line item, lost revenue from time meant for patients. The outsourced model stops this drain, while simultaneously allowing the practice to treat every single denial as a winnable appeal candidate. This AI-augmented workflow moves prior authorization out of the column of operational liability and into a predictable, fixed-cost pipeline. Adopting this model does not require changing your existing clinical software. Staffingly specialists work directly inside your existing EMR via an encrypted VPN. This means 0 screen shares and 0 manual data re-entry. The platform is trusted by 800 practices across the United States, fully aligned with HIPAA, SOC 2 Type 2, ISO 27001, and HITRUS standards. Leveraging this massive scale completely eliminates the need to ever hire, train, or manage internal prior authorization staff again. You can reclaim your 13 hours a week by visiting staffingly.com/demo. The barrier to entry is low. Practices can start with a 2-week risk-free pilot and be live in 5 to 10 days. Stop losing revenue to data mismatches. Rebuild your administrative architecture. Beat the Optum matrix and get back to the actual practice of medicine.